Just a little about us. My name is Bryn Blackwood, and I'm a benefits consultant with Maximus Rose Living Benefits. And in case you're unaware of what we do, we are a group benefits insurance brokerage. We work with all of the major insurance firms across Canada, and we provide customized and tailored employee benefit solutions to employers, along with healthcare spending accounts, retirement plans, and individual insurance options. And this morning we're joined by our Dr. Alan Steingart of Psychotherapy Matters. And Dr. Steingart is the founder of Psychotherapy Matters. He has been in practice for over 30 years and believes that psychotherapy and collaborative care should be the first line of treatment for all mental health issues and available to everyone. And he loves psychiatry and has made some significant research contributions. And Dr. Steingart will be assisting with answering our questions during the Q&A, both questions that have been submitted already and questions that you can feel free to submit during session. And we're also joined by Andrew Carr of Dialogue.
Hey folks, I appreciate you having me on board today. I'm an account executive here with Dialogue. My accolades are nowhere near as prestigious as Dr. Steingart, so I'll tell you a little bit more about Dialogue instead. High level, Dialogue is a health tech organization which works exclusively with organizations to really help support the well-being of their members. We do that by providing them with a healthcare platform that has a variety of programs available to support employee physical and mental well-being. Today we have two programs. One is primary care, which is unlimited access to a team of doctors, nurses, nurse practitioners digitally. And then we have our stress management and mental well-being program, which is focused on end-to-end support. And really is what I will be introducing today, as it is in line with the discussion topic. So excited to chat with you folks today and appreciate you having me join.
Thanks, Andrew. And just some housekeeping about questions. So I have received some questions which have been included in the presentation. And if you have a question that you'd like to share, you can email me. If you prefer to submit a question anonymously, we do have a link on our website, maximusrose.com/webinar-registration. And there's no information submitted with that anonymous question box. Or you can just send a private message or a message in the chat window, which is the chat bubble. And then you would select send to and my name, which is Bryn B. And just a quick introduction for Dr. Steingart and his Psychotherapy Matters. So I'm just going to play a quick video.
I can't hear the audio.
Oh, is the audio not working?
No, but I can explain it anyway.
Okay, sounds great.
So actually you can play it and I will talk to it.
Okay, sounds great.
No, actually I'll just expand on your very kind introduction and thank you for inviting me to participate. Oh, there it is. Now the audio's on. But not really. No, I can't hear it. I don't have control over it, right? I can't pause it?
I don't think so.
No. Okay, so before we started, can the audience unmute their mics and speak? Or they're only going to communicate with us through the chat?
I can unmute everybody or mute them. They can also send me a message and request to be unmuted.
Okay. So let's start this. I'll just start with a little introduction, then I'll tell you when to run this little video, although we might not need the video. As Bryn mentioned, I'm a psychiatrist, and I'm really happy to be here because I think it's so important for people to understand the complexity of mental health, which starts with the variety of providers. And there are so many providers that start with psych in their name. and the general public is very confused. So most people don't know the difference between a psychiatrist, a psychotherapist, a psychologist, and all of those categories of providers do provide mental health services of one kind or another. Some of you may have met psychiatrists, some of you may know more about this than others, but I'm a psychiatrist, so if you've never met one, here I am. And psychiatrists are different than other mental health care professionals because we went to medical school, and before we started into the field of mental health, we completed our medical training. We did an internship, so we have that background. And then nowadays, they spend an additional 5 years in the field of mental health. So psychiatrists are in the unique position of being trained in the medicine of mental health, the biology of mental health, and the psychosocial dimensions of mental health, the psychotherapies and the psychological approaches to mental health. And because of our training, we do a lot of different things. So some psychiatrists only provide psychotherapy. Psychotherapy are all of the talking treatments. And for all practical purposes, they look like any other psychotherapy provider, while other psychiatrists just prescribe medications. So they don't engage in in-depth or structured conversations or talk therapy. And the goal of Psychotherapy Matters was to make sure that psychiatrists were more accessible and could do the one thing that they are most suited to provide, which is the complex integration and understanding of patients or clients and advising on the best treatment course, which I've already mentioned is going to be some combination of the psychotherapies and the medications. So biologically, medically informed treatments, for example, medications, that's the most commonly used biological treatment, or psychotherapy, all of the talking treatments. Now, since no one professional can provide all of this, and as a result of psychiatrists trying to provide all of this, it's almost impossible to see a psychiatrist. There are 2,000 psychiatrists in Ontario, for example, and more than half of them see less than 60 patients in a year. And that's because they're doing psychotherapy, which is very labor intensive. Psychotherapy means meeting with someone regularly over a period of weeks or months. So that's one of the reasons why they're not accessible and they become almost irrelevant to the system. Now, what about psychotherapy? Well, psychotherapy is also difficult to access. Psychotherapy includes all of the talking, relationship-based treatments where you sit together with someone in a group or individually and you learn skills and you explore your condition and the strategies and approaches you can use to understand yourself better and to change your behavior or manage distressing emotions. There's really poor access to that too. One of the barriers is cost, but people don't necessarily even know what they need. And doctors are reluctant to prescribe psychotherapy because if they send you into the public system, it means that you'll have a long, you'll be put on some long waiting list. And if you go the private route, they don't want to get into a discussion with you about whether you want to pay or whether you have benefits. So that's become a barrier to psychotherapy. So the vision behind psychotherapy was to connect the dots, to bring these communities of practitioners together and build bridges. Because the single biggest problem in mental health is actually the lack of integration. The fact that the services you receive are not necessarily connected to your needs. They could be best predicted by the professional's office that you happen to walk into. So if you go into a psychologist's office, you're likely to get whatever psychotherapy that psychologist was trained to provide. And if you go into a family doctor's office, you're likely to be put on any medication that that family doctor feels most comfortable prescribing. So we try to create an alternative system where every door is the right door and a platform to make sure that people are communicating and collaborating with each other. That's the vision behind Psychotherapy Matters. So if you start the video from the beginning, I'll just briefly walk you through it. So the virtual clinic really refers to the psychiatrist, because the psychiatrist is always virtual. The employee, the patient, the client starts with a problem: addiction, relationship problems, anxiety, depression. They speak to their family doctor, and the family doctor can refer them to Psychotherapy Matters. You can use our website to learn more about the various treatments that are available. And you can also use our website to review the directory of providers who are in our network. We'll also guide clients through that process. Or the website can be used to do a self-guided search. The therapists on our network, these are the psychotherapy providers who are not physicians, they are enrolled and trained in our virtual clinic. So they've all been taught to work collaboratively with psychiatrists. They get their assessment with a therapist first. So the first place they typically go is to a therapist, although it could be a psychiatrist. Usually there's no psychiatrist easily available to them, or there's a long waiting list. So we come in and we'll do the virtual consult in collaboration with their therapist. Now with the coronavirus pandemic, we do three-way virtual, but the client can be face-to-face with their therapist. So that's the therapist and the patient sitting next to each other, and the figure in yellow is the psychiatrist. At the end of that process, a report is prepared and it's shared with the circle of care. So the circle of care includes the family doctor, the therapist, and the psychiatrist. That circle of care is how we define collaborative care, making sure that those are the three legs of the stool that the patient is sitting on. Patients have easy access to a therapist who's not only doing psychotherapy, but doing case management. They have easy access to a psychiatrist because the psychiatrist is linked to a therapist.
Okay.
And all of this is linked back to the family doctor, who's kept in the loop through access to the psychiatrist, access to the therapist. And that's our model of care. So if you want to learn more about it, then please visit our website, psychotherapymatters.com, and you'll see all the resources. And if you want your family doctor to make a referral, that can easily be arranged. And you can always contact us if you want more information. Someone will return your call or email. That's basically the story behind Psychotherapy Matters.
Thank you, Dr. Steingart. And we'll move into our question session now.
Okay.
So again, just a reminder, if you do have any questions, you can email me or submit anonymously at maximusrose.com, or message in the chat as well, messaging, selecting me as the viewer. So question 1 is about agoraphobia. So the question is, my father is 71 years old, and although he is in good health for his age, he's still at higher risk for COVID based on his age. Since the pandemic, he has become agoraphobic and has not been leaving his condo. He isn't even leaving for walks around the block. Is there anything I can do to encourage him to go outside? I don't think sitting in front of the TV all day is good for his mental or physical health.
Yeah. So if the person who asked this question is here, I'd be happy to hear more about the father. But this is, unfortunately, a common scenario right now. And it's part of what might be the second, we don't know yet whether we're going to have a mental health pandemic that coincides with the viral pandemic. But when people have anxiety, pre-existing anxiety disorders, then all of the public health measures have the potential to worsen their avoidance, their isolation, and their anxiety disorder. Now, this question is actually titled Agoraphobia. So I thought I will just briefly talk about phobias, because if you look up phobias, and if you're into word games or Scrabble, it's a really great source of very long words that you can learn. And typically they are a Greek name for something attached to the word phobia. So agora refers to a public square or marketplace. And phobia refers to an irrational fear. The phobias belong in the category of anxiety disorders. These are conditions where there's excessive and difficult to manage levels of fear. So the first question is, should we even call this agoraphobia? Because actually we should all be agoraphobic right now. That's one of the public health measures. We shouldn't go into crowded places where people congregate, and that could be the cause of an outbreak or infection of the coronavirus. So the question with phobias revolves around whether the fear is rational or irrational. And now the lines of risk determination are unclear. So with a 71-year-old, it's not really phobic to say, I don't want to go into public squares that are crowded or marketplaces that are indoors. And then the question is, what are the risks? Let's suppose that your father doesn't have a pre-existing condition, because agoraphobia is also associated with other anxiety disorders, particularly panic disorder. So since the question isn't about panic disorder, I won't go into a whole discussion about that. But agoraphobia can be linked to other conditions. And if it is in your dad's case, we'd have to figure that out. Let's assume, though, it has to do with his compliance with the public health measures. Well, then it's a discussion about risks versus benefits. And I like the way you put the question, because you're saying, yes, if he stays indoors, he can protect himself against the virus. But if he stays indoors and is sedentary, then he's increasing the risk of cardiovascular disease and of depression, actually. In fact, activity and exercise is protective against most of the common mental health issues, including anxiety and depression. And a 71-year-old, or people who are seniors like me, do benefit from exercise, both mentally and physically. So how do you talk to your dad about the risks versus the benefit? And for sure, the benefits of going out and practicing the unfortunately named social distancing, but what is essentially physical distancing and mask wearing, is really necessary. If you can't convince your dad, then maybe engaging the family doctor in that discussion. Because if his avoidance is irrational, then we have to help him to deal with that fear. All anxiety disorders have in common avoidance. At the heart of anxiety disorders is avoidance. The treatment of anxiety disorders, the psychotherapy treatment, is almost always involved in helping people to avoid avoidance or to face the things that they're afraid of. So determining exactly what your dad's afraid of and somehow compartmentalizing it into the things that really do involve risk and the things that are very low risk or practically no risk, having that discussion would be helpful. And looking, and like every risk-benefit decision, you'd have to look at the alternatives. So there are risks in not going out and not moving and not doing any kind of activity. And so you have to have a discussion about that, because you're quite right. That's not good for any of us, although it's been very common during this period, this very unusual and stressful period. Just as a final point about this, the Japanese coined this term they coined the term forest bathing. And there's actually research showing that going out into a forest and walking around has tremendous psychological benefits. And we don't even know the exact mechanism of that, because there may be a biological basis to it as well as psychological. Some of the resins from trees may actually have a direct calming effect when we inhale them. So that would be a wonderful activity for your dad, and you can select times when and areas, because I'm doing that with my wife. We go to parks and we just wander, and there's so many beautiful parks in Ontario that aren't particularly crowded, and just do hikes in those parks. So that's the kind of thing that would be really great. Although the weather's getting a bit cooler, it shouldn't prevent anyone from going out. And finally, there are a lot of activities you can do in your condo. Anything from buying your own exercise machine, like a stationary bicycle or a treadmill if the condo can fit it, to just a stepping exercise. There are a lot of classes that are on video that are accessible, and just making sure that he gets his heart rate up a bit and that he's engaged in some kind of physical activity. So I hope I didn't give you an overly long explanation, but I think it's a very common problem. It's a very real problem, and we'll see when things finally go back to normal, whatever that looks like, how much of these anxiety disorders will persist. So.
Thank you. And our second question.
Okay.
So my daughter is entering grade 9 and has social anxiety, and I'm afraid her anxiety will get worse since high school is partially online learning and kids are being encouraged to socially distance at school. How can I help her practice making friends and being social while social distancing?
Right. So this is another anxiety disorder question. And it's no wonder that it comes up because, as I mentioned, this is like the perfect storm for people who already have high levels of anxiety. That social anxiety is a particular kind of irrational fear or phobia. And I notice there's a definition on this slide. The features of social anxiety really have to do with a fear of judgment or of being criticized or of people's negative evaluation of you. And the first point I want to make is that virtual or video contact of the sort we're having right now is social. So in-person has tremendous benefits and it's preferred. And I'm guessing that when this is over, there may be a reaction against all video conferencing such that people will refuse to do it for months. I mean, everyone may be so sick of it by the end of this that they may actually say, we don't want to do this anymore. But in the meantime, you have to treat the video and the virtual as social. And so your daughter has lots of opportunities to be in social situations through video, through this kind of interactive video. That's why I wish we could unmute your mics and this would become more social rather than me just talking at you. If it's interactive, then it contains the ingredients of a social setting. But I'm going to try to imagine you, and I'm going to try to imagine your daughter. So there's a lot that she can do, even while compliant with public health measures. I'm going to introduce the idea.
Sorry, if I could interrupt you, Dr. Steingart. We have one caller who has called in and joined on the phone, and I'm not able to mute your microphone, and there's some background noise. If you don't mind just turning off your mic, muting, that would be really helpful. Thank you.
This is SB?
I believe so.
Oh, okay. Or maybe you have something to say.
That too.
Yes. So in terms of helping your daughter with social anxiety, I think that you can provide lots of social anxieties even within the virtual, lots of social experiences within the virtual space. And again, the rule, the cure for anxiety disorders, I've already taught you the mantra, avoid avoidance. After you determine whether it's an irrational fear, then all the treatments for phobias involve exposure. Exposure is avoiding avoidance. So it's very important for someone with a social anxiety disorder to have experiences talking to people, interacting with people, even experiencing judgment or criticism. Now, there's one feature of social anxiety disorder which is not sufficiently emphasized, in its treatment. By the way, there are medications for anxiety disorders too, and I'm not going to talk about them right now because they should always be the second line or even third line of treatment. Because medications can become part of the strategy of avoidance. And what did I already tell you? What's the cure for an anxiety disorder? Maybe our panel can say it. What did I say?
Avoidance.
Avoidance, yes. If you remember that, you've learned a lot. If you remember what psychiatrists are and how great they are, how useful they are, and their unique training and role, and if you remember to avoid avoidance and apply that to your own irrational fears, then you can do a lot of good for yourself and for others. So one of the features of social anxiety disorder, if your daughter really has the full syndrome of social anxiety disorder, is that exposure by itself isn't enough. And what we've learned is that people with social anxiety, even if they have a lot of experiences that are successful, so for example, they're terrified of speaking in public, doing a presentation, and then they do a presentation and it goes really well. And everyone tells them they were amazing. They nailed it. It was a great presentation. You ask that person after and they'll tell you, I was sweating, I was shaking, it was terrible. People are just being nice. People don't want to be rude to me. They're not telling me the truth. So in other words, they take these exposure experiences and they devalue them or diminish them. So no change can occur. And as a result, exposure by itself has been shown to be, it's only partially effective. And one of the things that is used now in a modified form of cognitive behavioral therapy for social anxiety disorder is to make recordings of people in a social interaction, asking them to rate themselves on how they think they appeared, how they think they sounded, and then show them or review the video. So this can be done by a therapist trained in this model of psychotherapy. And it's a kind of exposure plus, because in order to change self-perceptions and self-evaluations, you have to have the capacity to take on an observer perspective. That is to somehow be able to observe yourself or see yourself as if watching a video. And it turns out that people with social anxiety disorder, if they have the full syndrome, if that's truly what it is, benefit a lot from changing their self-evaluation through self-appraisal of a video. And this is particularly suited to what we're doing nowadays, which is video conferencing. If you ask a person with social anxiety, for example, how do you think you looked? They'll say, my face was totally red. There was sweat pouring from me. And so you ask that person to rate, how red do you think your face was? You can even give them a color chart and say, okay, this is just a little bit pink and this is bright red. Where do you think you are? So they'll say bright red. And then you show the video, you hold the color chart up, and of course, they're not. No one can see it. That actually helps people with social anxiety to move their self-perception.
That's so interesting.
So in social anxiety disorder, there's this internalized model or a view of yourself that's very hard to move, which is why exposure is more difficult. This seems to be more difficult as a treatment by itself. This seems to be less of a problem with other issues. Like, for example, agoraphobia can be treated by getting that person to go out. Motivating them to do that is challenging, but as soon as they're out, like if your dad in the previous question was very, very anxious about going out and he had developed a phobic avoidance of going out, after going out a few times through simple exposure, his anxiety would diminish and he would more skillfully manage whatever anxiety arose. But with social anxiety, you have to add this other component, which is an argument for finding the right therapist. And that's what Psychotherapy Matters is about. It's not just about finding the right medication or finding the right technology or finding the right app. It's about matching the service to that person's specific needs.
Thank you. I found that so intriguing, especially the idea of them going on video and how that helps with
Yes.
treatment. So thank you. That was fantastic.
Yeah, but you have to work with someone. You can't, I mean, a person viewing their own video may turn it off, or they may become hypercritical. So just viewing yourself on video, like looking at yourself in the mirror, which a lot of people have difficulty with, can by itself is usually not successful. You have to be working with someone who can both motivate you and experience. This is, you know, the characteristics of a good therapist are someone who is empathically resonating with you. That is, they understand you, they care about you, you feel like you can trust them. And that relationship becomes a bridge to facing your fears and your anxiety. If the relationship isn't good, then you can't do much work together. But having that relationship with a therapist is powerful. And that's why it's worth the effort to find such a person.
Thank you.
You're welcome.
And our next question. So it's regarding depression.
Yes.
I'm having a hard time with my son. Like most other grade 12 students, he missed most of last semester in class, as well as high school graduation, prom, and summer celebrations for grade 12 students. He's doing his first semester of university online from home, missing out on living in residence since university is now just online. Now just online learning until next semester, provided that there are no second wave shutdowns. He's become very pessimistic, and I'm worried he's depressed. I tried to talk to him and be encouraging, but his outlook on life has become very negative. What can I do?
So, you know, my heart really goes out to children and young people, including teenagers and young adults, because they've been impacted in all sorts of ways that are quite unfair and not really directly related to the virus itself. Although they're not immune to the virus, and there's some children that have died or become very sick, in general, this is a big problem for older people like me, and less of a problem for their generation. And yet the consequences have been very dramatic in essentially shutting down their lives. And for many of them, they've had to put their lives on hold. So I think this is a really big problem. And some of your son's pessimism about the world right now isn't entirely irrational, considering all of the events that are going on and the challenges that his generation is going to have to face and to fix. But I'm very optimistic about that generation. I really like them more than my own and the ones right after mine. So these Generation Zs, I think they're really great. And a little bit of realistic pessimism, I think, is okay. It grounds them. Now, having said that, I'm going to take this opportunity to differentiate between what we might call clinical depression, what a psychiatrist would diagnose, and existential depression, or the normal sadness and frustration as a result of life's unfairness and as a result of pain and loss. Because your son has already lost his prom, his graduation, his summer, and now he's going to lose the opportunity to go into residence and to start university and all of the excitement and experiences that go with that. So acknowledging that is a good place to start. But is he clinically depressed? And by clinical depression, we refer most commonly to a syndrome called major depression or major depressive disorder. So how would you know whether your son is just feeling bummed out, sad, low because things suck right now, or he's clinically depressed? And depression is an epidemic in young people that existed before the virus pandemic. We knew that there was an epidemic of depression in this generation. So it's very unfortunate that we named a syndrome after one of its symptoms, and believe it or not, you don't even have to have that symptom to have the syndrome of major depression. So I would vote for renaming the whole thing. but we've named it after one of the symptoms, which is a feeling of sadness or feeling low or feeling down. Now, I should emphasize, you actually don't have to have that symptom to be suffering from the syndrome of major depression. What are the other symptoms? Well, the other symptoms, which you can check with your son about, are difficulties with sleep, difficulties with appetite, either eating way too much or not eating at all, difficulties experiencing any pleasure or joy. I should mention that it's not just that the feeling of depression has something in common with what I'll call normal depression or sadness, but if you ask someone who's suffering from clinical depression, is it like normal sadness? They'll tell you no, it's not the same as just feeling sad, because it's persistent and it's pervasive. It doesn't lift. It doesn't react to stuff that, you know, should make me feel better, even for a few minutes. So another feature is this lack of the ability to experience joy or happiness. And then there can be agitation or slowing down. There can be physical fatigue, lack of energy, can't even get out of bed. It's hard to get out of bed. And finally, there's the issue of suicide or thoughts about death. And that's on a spectrum from thinking the world would be better off if you were gone, or you don't matter, life is pointless, worthless, to actually having thoughts about ending your life, and finally having a plan, something you're going to do. Now, I'm just going to again emphasize something that you probably already know, which is that asking people about suicide doesn't increase their risk of suicide. So if you ask someone if they have thoughts about death or ending their life, that's an okay question to ask someone. It doesn't plant the idea in anybody's head. Most of us, all of us really are afraid of dying, and you want to encourage that. And many people who are depressed operate under the assumption that no one will care or that the world might be better off. And that's just not true, right? It's the most horrific loss imaginable. And telling people that can actually help them to manage their distress. So that's the syndrome of major depression. It can affect people at any age. If it's very severe, it can cause the person to just basically be in bed all day, not eating, not sleeping, not doing very much. And there's this big gray zone between, you know, what would be a normal teenager's angst and, you know, doing their own thing, and the syndrome of clinical depression. And I would say one of the big dividing lines is that they're not able to function at all. Nothing, like it's interfering with their functioning, and you're concerned about their safety, because safety would be a big problem. Now, in terms of helping a teenager, young adult who's in that situation, I'm just going to repeat the story about that. Virtual is social. Although the universities are maybe temporarily switching to no in-person or lecture hall classes, there are other places that they can interact with people or work as a volunteer. Now, I was just going to, the final comment I was going to make about this, because it applies to all three of these questions, is the idea of bubbles. So the public health measures have to do with making sure that outbreaks, if they occur, are limited, and protecting people who are at risk. Until we have really good therapeutics or we have a vaccine, we want to protect people who are at high risk. And there is a very clear risk stratification. The older you are, the more serious it is. So when it got into the nursing homes, a lot of people died because those were old people with coexisting diseases. So we know now that if you're any age and you've got hypertension, heart disease, kidney disease, then you're going to be at higher risk if you get this infection. So we have to put a bubble around those people. And it took us a while, for whatever reason, to get our act together on that. Similarly, you want to bubble the people in your life who are at risk, older people, like the 71-year-old father. But there are people who can move into the bubble. And you can begin to merge bubbles if people are all being very compliant with public health measures. And similarly, your son may not need to be protected to the same degree as the 71-year-old father, but he may need, if it's possible, to be separated from infecting other people who are at risk. So this is another one of those cost-benefit analyses, because if your son is feeling isolated and completely detached, there are opportunities to be with people and to contribute, both as a volunteer. For example, in the school system right now, they're looking for volunteers to help them with young kids, because and then some of these positions are even paid, where they are making the classes smaller. So someone at his age might be involved in that, just helping some of the teachers. You don't have to be a teacher. It isn't a teaching responsibility, for example. But there are other activities that you could do both online and in person and still be compliant with public health measures. And then a simple acknowledgement that, yes, things are bad right now, but they're going to get better, because they will get better. We will get through this. And I think Bryn mentioned that she wanted me to say something optimistic about all of this. Or did you? Was that one? Or
Sounds like me.
Because I was just going to say something that may not be correct, but I have a sense that it might be true. You know, we think about, well, social isolation is the way we've defined the major public health measure to prevent spread, because the virus doesn't have legs or wings or anything. We are hosts, and it has to go from host to host, and it does that when we breathe, when we cough, when we put virus on materials and someone else touches it. So we have to be reasonably close to each other for that to happen. So there is this isolation which has emerged as a consequence of all of the public health measures. But isolation, social isolation, is actually a feature of every spiritual tradition to help people to grow in wisdom and in inner resources. So there may be another one of those unexpected benefits, that a generation of kids will be more skillful at being alone. And being alone with your own thoughts, with your own feelings, is actually a very good thing, especially because all of our technology and our culture conspires to keep us engaged in distractions endlessly. So I would even introduce some of the practices that go with isolation and that have benefits. Maybe Dialogue is doing one of these programs where you teach people how to practice mindfulness, how to do meditation, how to sit with your thoughts or your breath. And instead of thinking of all of this as some kind of horrific stress, there is a kind of opportunity. And another thing that's really been positive from the mental health perspective, because from the beginning when I launched Psychotherapy Matters, we were a virtual platform for psychiatrists, and some of the therapists were virtual, but not the majority. And one of the barriers for adoption of our approach was that a lot of people did not want to do anything virtual. They were afraid of the technology. They didn't think it would work. Well, now everybody who is in practice has had to at least try virtual platforms or they're out of business. And it has accelerated what is a necessary transition in mental health. And in some ways, you have better access to mental health care now than you ever did, because mental health care, to a much greater degree than any other aspect of healthcare, does not require in-person experiences. There are a lot of benefits to meeting with someone in person, so I don't deny that. But you don't have to have in person the way you would, let's say, to have a physical examination or to have certain kinds of tests. So now I just realized I've gone over, and
we did have another question submitted, actually, Dr. Steingart. I'll jump to that one. So it's a two-part question. What are some of the ways healthcare providers are assisting with deconstructing systemic racism and its effect on mental health is the first part. And then the second is, and I can reiterate, how are they addressing it within the care they provide as well?
Well, I think in Canada, we have a very diverse medical workforce. So I don't think that there's a lack of voices or a lack of representation within the community of professionals. And I would say that the colleges have all, within the universities and within the regulatory colleges of the healthcare professionals, there's always been an attention to this. And I think it's been heightened because the focus is on these issues right now, perhaps more than it has been in the past. So this issue in psychiatry has been addressed on many levels. For example, I think this week the Ontario Psychiatric Association is going to have a virtual webinar on precisely these issues and how you adjust your approaches, what the risks are in helping people with various cultures and ethnicities. When you're coming at them from wherever you stand, how do you manage that? Within Psychotherapy Matters, we allow the patients, the clients, to choose a therapist as well. That's one of the many criteria that they can use in our algorithm or in our search engine. If they would feel more comfortable with someone who is familiar with their lived experience, they can choose that. And we honor that if that's what that person chooses. Sometimes people specifically want a therapist who is not of whatever group they identify with. So you can't always predict. But I think there is no simple answer to this. And there's the notion that under stress, systems crack. And I think this is particularly evident in the United States. But it's the cracks that let the light in. And maybe that's another one of the consequences of the pandemic, that people are becoming more aware of these issues and the light is coming in, because this systemic racism and hate grow best in the dark. And it's another benefit of, I mean, I wouldn't wish this on anyone or on the whole world. I mean, this is a worldwide phenomenon, but it's another thing that sometimes I think about from the more optimistic perspective. I think the pandemic accelerated the need to address these issues because it showed how certain communities are at greater risk, and it's because of the social determinants of health. It has nothing to do with genetics or race itself. So it's another example of an unexpected consequence, only unexpected because people with power don't pay attention to any of this. So I'm sorry if I gave an overly long answer, but that's my perspective on it.
Thank you. I'm going to hand things over now to Andrew so he can talk to us about dialogue and their virtual care and some of the new programs that they're offering as well.
Perfect. Thank you so much, Bryn and Dr. Steingart. That was awesome. Amazing perspective and super insightful. And I'm taking away a lot from this myself. So I know everybody else on the audience definitely probably saw some value in that too. And I mean, one of the things that I take away from that discussion is just how personal and specific a lot of these mental health challenges are. And to Dr. Steingart's part, a lot of people don't know how to approach getting help or how to come forward. And a lot of the times, many of the times, these individuals are employees, are colleagues. And speaking with HR leaders on an ongoing basis, I know a common theme, especially in today's pandemic, is how can we better support our employees, today and into the future. And Dialogue's in a great position to be able to help Canadians across the country. And I'll just give you a bit of background again, because I know that previous summary was pretty brief. Dialogue works exclusively with plan sponsors, and we really work to be in an organization's total rewards program and really help organizations build a health platform and a health program for their employees. We have over 1,000 daily visits on our platform today, and really have seen exponential growth, especially in today's pandemic, with over 1,000 clients on our platform and millions of Canadians with access to Dialogue. And what is Dialogue? If I take a step back, it's a application you can download on your phone. It's also available via web browser. But today there are 2 programs available to plan sponsors. We have our primary care, which is unlimited access to doctors, nurses, nurse practitioners, mental health specialists, 24/7, 365 days a year in both English and French across the country. And then we also have our stress management and mental well-being program, which is really focused on end-to-end support for employees when it comes to mental health. And a third program coming in the new year, which is an EAP. But all of these programs tie together seamlessly, or can be used as a solo option as well. Dialogue started off as a primary care solution. And from there, we've always wanted to be innovators in the space, and we have a mandate to continually look at, our data to innovate and see how we can, improve our programs that are existing, but then also see if there's a possibility to, help our members to a further extent. And that's really where our mental health program came from. We took a look at the, aggregate data for our entire organization, and what we noticed was that, people were using Dialogue for mental health related purposes for our primary care solution. So we had doctors, nurses, nurse practitioners who are trained to deal with mental health related issues, but it's not their focus. So 20% of people were using us, and we have a extensive partnership with organizations where we build out a communication strategy and promote the service on an ongoing basis. And we weren't even focusing on the mental health side of things, but people were needing that type of help. So we thought we were in a great position to really expand on how we were helping our members and offer an additional strategy. And obviously with I think Dr. Steingart mentioned it around the scope of practice, or the application of virtual consultations for mental health. It has quite a wide scope. So we thought we were in a great position to build on our success with primary care and offer support from a mental health perspective as well. But we wanted to take a bit of a different approach to some of the current solutions in place, because there are some amazing programs out there, in the public sector, but then also privately as well. You have your EFAPs, you have group insurance allocation to a psychologist or a psychotherapist, which are unbelievable benefits, and they provide a lot of flexibility, and they're unreal safety nets. But there's still a lot of barriers to accessing care for individuals. There's still that fear and that stigma associated with coming forward for help, which is hopefully being broken down by these conversations, and things like Bell Let's Talk. People might not even recognize that they're experiencing a mental health related concern. Waking up in the middle of the night and not associating that with mental well-being. If somebody does finally come forward to get help from HR leaders like yourself and really rely on the organization, you go to your typical EAP, and this isn't all of them, but your typical experience for an employee is 3 to 5 sessions with a counselor. From there, you typically have to rely on your own proactive approach to find a psychologist or a psychotherapist externally, where your typical allocation for paramedicals when it comes to psychology or psychotherapy within an HR budget is $500 to $1,000, which is another 3 to 5 sessions realistically. So it can end up being costly for an individual when extended treatment is needed. And throughout all of this, there's this fragmented care journey where not necessarily your therapist is speaking with your family doctor to really provide that multidisciplinary approach to care and helping individuals achieve functional remission. So Dialogue's trying to take a different approach to some of the solutions and really complement those existing solutions. But these are the 3 pillars that we focus on: proactive outreach, end-to-end treatment, and an outcomes-driven approach, right? Focusing on, putting a plan in place and focusing on getting a person back to health and achieve their health goals. And if I dive into that a little bit further and what that means, this is that first pillar, right? The proactive outreach. So Dialogue, I mentioned, has an extensive way in which we partner with an organization. So you get a full and account team who would help you launch the program, communicate the program. But then after the fact, you get an account manager once the program is launched to go through analytics, talk about engagement, usage, and if we need to iterate on the communication strategy to see higher adoption, we can do that. We partner with you to understand that and take a strategic approach to your programs. For the communication, we are putting on a variety of different things like webinars to educate employees and educate managers on, how to have that conversation, recognize that you might be experiencing mental health related symptoms. We also do things like email campaigns, and we have, digital signage, and a couple of examples here of some of the resources that we have available. We did a weekly campaign with emails for Mental Health Week, where there was tips and tricks on how to reduce stress, healthy eating, a video of a personal story that used our platform. But then throughout that entire email campaign, we're educating individuals of the resource they have available to them. Because you can never tell when somebody is going to have a mental health related incident, and there could be triggers throughout somebody's year that do send somebody on a downward spiral. And it's about continually educating and making people aware of what they have available to them, so that when they do need it, they know where to go. And throughout all these different resources that we utilize, we have things that are driving people to our application, trying to get them to register for our program so it's easy to use and easy to access. And just to give you a sense of how powerful this is, 75% of the individuals who have gone through our program were actually pulled in using these types of proactive approaches. But what happens when somebody enters into the program? What we're really trying to do is drive people to fill out a questionnaire that's embedded within our triage system. It is the PHQ-9 and GAD-7, pretty widely used in the EAP industry as well. We've whittled it down to 2 to 3 minutes, but when an individual fills out this questionnaire, what it allows us to do is really place them on a spectrum of stress, anxiety, and depression, and really offer them an individualized program that is case managed to help improve their scores over time. And somebody might not be experiencing high levels of stress, anxiety, and depression, but we still have a way to support them. And I'll be fully transparent. Beginning of the pandemic, as you can imagine, virtual healthcare became such a widely adopted tool. I was working 21-hour days just trying to get this in the hands of as many Canadians as possible, and I was feeling pretty burnt out. And I used this, and I spoke with one of our mental health specialists who was able to provide me with tips and tricks on meditation, which I believe Dr. Steingart chatted about, creating a habit over 21 days. And I now meditate on a daily basis. He even gave me a free breathing tool. So even for me, where I wasn't experiencing high levels of any of the above, I still found value. But really where this differentiates itself from, programs that are in the space today is we offer this case managed approach where somebody's checking in with you, making sure you're getting the help that you need, and just making sure that you're feeling all right. We have a multidisciplinary approach where we have doctors, nurses, nurse practitioners, but then also psychologists, psychotherapists, as well as our mental health specialists available to employees. And we offer uncapped access to CBT psychotherapy sessions with our psychologists or psychotherapists. What we do is try to take a strategic approach where, we will use our evaluation of the individual, we'll put a plan in place, and we're going to, check in with an individual, reevaluate them throughout the sessions to make sure that what we're putting in place is improving, their mental well-being and helping them achieve functional remission. And if somebody is experiencing an issue today, goes through 3 sessions with us, and they feel better, and 7 months down the line, they have to use this again, they're able to do that, right? It's uncapped access to our program. Obviously, there are some things that fall outside of the scope of practice when it comes to virtual consultations, but there is a broad scope for CBT psychotherapy. And even in instances where, virtual consultations aren't going to be the endpoint, we're not just going to leave you to your own devices, right? We have a full team of care navigators who are going to help you locate and find the right resources, and we can even help you book those resources externally as well. And we're seeing some great results. If you want to chat further about some of the specific ROI that I can just drive up for you and get for you, we can do that, set up some time separately. I'll provide my contact information to Bryn. But these are some of the results that we're seeing in terms of satisfaction. And you can see 98% of employees were satisfied with the program. 100% of employees found the service fast and efficient to fit your schedule, right? To give you that flexibility. And 98% of employees were able to address their primary mental health needs. So some great stats there. And we're only continuing to see, a growth in organizations interested in how they can further support their employee base in this time. And we have some great organizations on our brand today, or on our platform today. One that I always love to point to and we're super proud of is the Mental Health Commission of Canada, who jumped on, I think it was the end of last year, onto our program. I know we might be running over on time. I want to make sure there's any questions, and feel free to reach out to me with any other questions. I'll provide you my contact details, and if you want a deeper dive, this is very high level, we can jump into it as well. But thank you so much.
Thank you so much, everyone. Does anybody have any questions that they'd like to submit? I can share my screen again.
And one thing I would preposition is that I am not a medical expert. So if there's any specific medical questions about how our platform would deal with certain situations, you can submit those to me and I will try to get those answers to you from people that are much smarter than myself.
Also, please feel free to follow up with a question and email as well. Okay. Well, we're going to wrap it up just because we are over time, but thank you so much, everybody, for attending. If you do have questions, please feel free again to email, and I'll make sure that they're directed to Dr. Steingart and Andrew. Andrew, what's your contact info?
It's andrew.carr@dialogue.co, not .com. It's a confusing one, .co. So my first name, last name @dialogue.com.
And I'll make sure to send that a follow-up to everyone, all the attendees as well, with that information in it.
Perfect.
Thank you so much, everyone, for attending, and we look forward to hearing from you.
Bye-bye.
Thank you, everyone.
Oh, yes, and thank you, Dr. Steingart, so much. Oh, it does look like I got, oh, no, it was just a thank you. Thank you so much, Dr. Steingart. Your responses were so thorough and so intriguing, and we're so grateful to have you on and learn about Psychotherapy Matters and have you answer these questions. It's invaluable to us.
So I'll also put a last plug in for Psychotherapy Matters in our virtual clinic. You can reach us. You can reach me at Allan, A-L-L-A-N, at psychotherapymatters.com. Go to our website. There's a phone number too if you want to call. And I didn't go into programs that we have that are specific to keeping people at work and returning people to work who are on disability. So we have specific teams that address those issues. I didn't mention that. And I guess what differentiates us is that it's the patient, the client, the employee sees a psychiatrist first. So we're interested in the employees, clients that are more complex, that need a more detailed assessment and a more specific plan. So thanks for attending, and I hope that this was helpful to all of you.
Thank you, Dr. Steingart. We really appreciate it. And we'll follow up with his information as well. Everyone, enjoy the rest of your day. Thank you for attending. We really appreciate it.
Bye all. Thank you.